There we go. So once again, welcome everybody to our annual meeting. We're all very excited to have you here. Okay, so let's get started. I am going to turn it over to our Executive Director, Judy Keeney, for some opening remarks. So Judy, please take it away.
Great. Thank you so much, Daniela. And it's great to see everyone this evening. 140 people counting. It's just great to see you. This is my third annual meeting with End of Life Washington. And as we look out across the Zoom room, I'm wondering on my view, is Shyla still up, or is everyone able to see either me speaking or there we go. Great. So as we look out across the Zoom room and see old friends and people we don't know yet, I propose that there are two values that unite us all. The first is that each of us understand that dying well matters. Dying well matters in the same way that how we come into the world or how the quality of our life matters. Yes, so dying well matters. Our last days, our last moments, our bodies, our dignity, our personal sovereignty matter up to and even after our final breath. I think the second thing that will unite us all is that having end-of-life care systems that support our basic human desire to die well is worthy of educating and organizing around, fighting for, supporting, and protecting. Now, it's easy for me to say and much harder to do. Aligning care, policies, and systems to support dying well is challenging. So even though medical aid in dying is supported by the vast majority of Washingtonians and has been legal in the state for coming up on 14 years, there are still too few medical providers prepared to support patients' access to medical aid in dying, much less to know how to support a patient's wish to voluntarily stop eating and drinking. You know, End of Life Washington is consistently supported in some capacity or another 90% of the people accessing medical aid in dying in Washington state. And that was okay when there were a few hundred people across the state trying to access the Death with Dignity law. You know, between 2012 and 2019, End of Life Washington's client growth was relatively stable, about 10% growth a year, maybe 30 or 50 new clients annually. In 2020, though, we served 550 new clients. This year in 2022, we expect to serve 850 new clients. And I expect next year in 2023, we'll serve over 1,000 new clients a year. That means in 4 years, the number of people End of Life Washington serves will have doubled. And this growth has stretched our staff, our team of volunteer client advisors, our doctors, even as new volunteers come on board and join us monthly. And so I want you to know that when you see like staff growth, or when we're reaching out, inviting you to donate to support End of Life Washington, it is purely to respond to this rapid client growth that we're seeing. We're identifying a combination of factors that are contributing to this client growth. One, COVID has more and more people facing mortality, and that includes seeing, more deaths with significant suffering. In Washington, in a state like Washington, more and more people are talking about death and dying, providing services that support people to die well, increasing people's awareness of end-of-life choices. And we also know that Washington's population, our nation's population, is also aging and growing older. So all these factors come together to create what I'm seeing as a growing expectation that dying well really matters. And I don't see this expectation reducing or softening anytime soon. This past March, when it was clear that our barriers bill, HB 1141, was not going to pass, and that the legislative process could never keep up with client demand, we launched the Aid in Dying Provider Network with funding from a very responsive and generous group of folks we're calling the visionaries. And later this evening, you'll hear about the Aid in Dying Provider Network from Cassandra Sutherland, our Client Services Manager, and Dr. Jess Kahn, our new Medical Director, as well as hear about the research that Dr. Elizabeth Loggers and her team is doing related to people's experience in accessing the law. I think it might be helpful to understand that End of Life Washington, potentially all of us, are in the middle of a confluence where on one side, there is this growing expectation of people, expecting that, when their time comes that they want to die well. And on the other side, our systems, health, spiritual, community, familial, are ill-prepared to meet this and respond to this moment. We're living in this highly adaptable time, this moment, and everything is evolving so quickly. Recognizing that there's no normal to return to, how do we go forward? I'm seeing 4 strategies that we can take that build on our efforts to date. And the first is, I think it's the most important, is let's be bold. Let's be bold in advocating and supporting and reclaiming this basic human right to die well. The vast majority of Washingtonians support end-of-life choices, including medical aid in dying. Close to 70% of people nationwide say that if they had an incurable terminal disease, they would want the option of medical aid in dying. We are not a fringe movement. Let's make this case that dying well really matters loudly, proudly, and compassionately. And by focusing on dying well, it allows us to build our skills and create an organization where more Washingtonians feel like End of Life Washington belongs to them. We are very blessed to work with the new transitions team, including Norma Timbong and Anjuli Ganti. Their understanding of aging, the intersections of aging, public health, equity, inclusion, diversity, and belonging is such a great alignment with End of Life Washington. And you'll hear from Norma later in this evening. The second strategy is that let's work to ensure that our end-of-life care systems are as robust as our efforts to support individuals. I think this is where we really need to do some rebalancing. And we're really helpful about what we can accomplish with Dr. Jessica Kahn and CASA and the rest of our team, what we can accomplish working across health disciplines throughout the state. Our efforts in Olympia are definitely systems building in nature, and we're working with a few elected officials to reintroduce our version of HB 1141 that maintains core protections of medical aid in dying, but eliminates the barriers to care. You'll hear more about that later this evening. I think the third area that I think we can do is to working across both individual and systems is to organize regionally. End of Life Washington has always organized regionally for client services. And over the next few years, you will see us see regional teams of volunteer client advisors, whether it's health, spiritual, community, or familial systems providers, ambassadors, working together to support their neighbors who are in a position and wish to die well. The fourth area that I want to propose is that we collaborate and support kindred movements. And with close to 50% of medical care systems operating within the state of Washington with medical exemptions, we understand that the threat to bodily autonomy and personal sovereignty. We would not be in this position of fighting for a basic human right to die if bodily autonomy and sovereignty were valued. Aligning with our kindred movements that are focused on bodily autonomy, like reproductive rights, trans rights, movement for Black lives, and other movements, allows us to contribute to each other's efforts and helps to protect what is at the heart of dying well. And that's really a personal decision related to our body. So are we going to accomplish this tomorrow? No, we're not. Are we going to accomplish this alone? No, we're not going to do that either. But we are adapting in the short and the long term. And I hope that you find things this evening that inspire and inform you to get more involved in End of Life Washington. We can accomplish so much more together. Before I wrap up, I want to shout out really quickly to our new board president, Teresa Chiftis, 2 new board members, Cindy Nover in Eastern Washington and Sue Curry, and our entire board. I want to thank our volunteers, VCAs, volunteer providers, ambassadors, and storytellers. Thank you, community partners. Last and especially not least, I want to thank our talented and dedicated staff team for all they're doing. Tonight and in our work together in the coming days, let's let the larger reason why we're here guide us. Dying well matters. Thank you so much.
Thank you, Judy. And next up, I'm going to hand it over to Casa Sutherland, our Client Services Manager, to tell us a little bit about the provider network and introduce our new medical director. Okay, Casa, take it away, please.
Thanks, Daniela. Thanks, Judy. Thanks so much for all of you for joining us tonight. It's really great to see you all here. In our few minutes together, we will be discussing the Aid in Dying Provider Network and the goals of the project over the next 3 years. This project is a priority effort for us. It was born in the summer of 2022 in response to the level of growth we are experiencing. We had really hoped that over the last 2 years, their advocacy efforts would allow nurse practitioners and physician assistants to participate in medical aid in dying. But unfortunately, it's just not moving quick enough, and our provider growth is not matching our rates of client growth. The goals of the Aid in Dying Provider Network came from extensive conversations with providers, community members, and volunteers, and we were able to begin this project thanks to the group of visionaries who are supporting it. There are simply not enough providers supporting the patients, their own patients, to access medical aid in dying, either because their employers do not allow it or because they lack the support and sometimes knowledge on how best to help. I really can't help myself but go off my script here and just mention that 20 minutes ago, I got a call from a woman in Spokane who had spent months and days trying to find us and our organization. She had spoken to her provider and her social worker, who both told her that absolutely not, they would not help her access medical aid in dying, and they would not say any more. She's blind in one eye, doesn't have a computer, and she found us by listening to YouTube videos through her phone. And she's an example of why this project was created and why we need to do better for folks. We want our medical systems to be accountable and to provide the legal healthcare available in this state. When a person approaches end of life, our vision is that Washington providers are knowledgeable, that they are supporting their patients and providing accurate information. And if they can't participate, they refer their patients to colleagues who can. So the project is laid out over 3 years as we build, expand, and sustain over this time. The first priority was hiring a medical director, and I'm looking forward to introducing you to Dr. Jess Kahn here momentarily. But secondly, we depend so heavily on our community-based model of physicians, some of which are in this room today. The physicians who volunteer with us see hundreds of clients a year. And a goal in this first year of the project was to expand our volunteer physicians by at least 10 people. This allows us to ensure that we can support our current clients who need providers. And I'm thrilled to share that we have added 5 new providers already, and we're still counting. Additionally, we know that providers are looking for more opportunities to learn about medical aid in dying. Throughout all 3 years of this project, our focus is on education. In October, we offered our first physician networking event, and these will continue quarterly. In these first months, we've also been meeting with new physicians, recruiting folks to support their patients, and doing presentations across the state to providers. Over the course of this project, we will expand the educational offerings for providers through peer support and professional development. Finally, in this first year, we're also supporting the work of Fred Hutch's team in a study on the barriers to accessing medical aid in dying, and you'll hear from Dr. Loggers later on in this hour. In our second year of this project, we'll continue our advocacy efforts to get nurse practitioners and physician assistants to participate. This change is crucial to expanding access in underserved areas and reducing barriers across the state. And by year 3, the burden on our volunteer providers will be lessened and will be in a more sustainable place. This project is really about creating a system change. End of Life Washington cannot be the stopgap for this care. We need healthcare in Washington to incorporate medical aid in dying into standard medical practices. We're only a few months in, and we're really already well on our way, gathering with providers, meeting with pharmacists, coroners, and giving presentations from Whidbey, Vancouver to Spokane. As I mentioned earlier, an integral part of this project is the role of the medical director. And for years, Dr. Bob Wood has been a crucial medical advisor to this organization, making sure hundreds of clients had access to medical aid in dying. However, we continued to hear from our community that what we needed was a paid medical director position that worked specifically to expand recruitment and outreach. The medical director's position is to help change the system of medical aid in dying, increase the number of participating providers, and aid in the creating of professional development opportunities. In September of 2022, we welcomed Dr. Jess Kahn to the team. Dr. Jess Kahn received her medical degree from Des Moines University. She completed her internship and residency at Providence Portland Medical Center, where I'll mention she was not trained in medical aid in dying. Then served 3 years in the National Health Service Corps, providing high-quality medical services to the underserved populations of Eastern Puerto Rico. Her special interests include population-based healthcare and the integration of high-quality research and alternative medicine. I'm going to let Dr. Kahn tell you the story of how she became involved in this work, but I want to acknowledge that one of her many gifts that she brings is her clinical experience. Before taking on this role, we depended heavily on Jess for her to be the attending physician for many clients in Southwest Washington, and she believes patients are best cared for by their own practitioners. And she hopes that in this role as EOLWA's medical director, more providers will be prepared to support their patients' choices. Dr. Kahn has already begun in full swing, helping to encourage providers to support the end-of-life choices of their patients. She's coordinating services, ongoing opportunities, peer support, and networking, and we're thrilled to have her join the team. So please help me extend a warm welcome, and I'll pass it over to her.
Thank you, Hassa. I'm so happy to be here. I'm so happy to see this turnout. This is just really heartening to see that so many people are here to hear and to support the work that's happening across the state for medical aid in dying. Why I'm doing this work is an interesting kind of meandering story, but you know, the short version is that my father's from the Netherlands, and so within my own family, I've been a supporter of medical aid in dying, and it's been something that is just seen as fairly normal because of that cultural background. But of course, in America, that's a very different story. I had a family member that chose medical aid in dying back in the 1980s in Belgium, and so that was always a big part of just how we saw choices for end of life. As Casa mentioned, I was trained in Oregon, where medical aid in dying has been legal for a long time, but I was trained at a Catholic institution at Providence. And so although I was aware that it was a legal option for Oregonians, I never received any training at all during my residency regarding medical aid in dying. And, you know, I'm an internal medicine doctor. I work as a hospitalist, meaning that I work only in the hospital, not in a clinic-based setting. And it didn't seem particularly relevant for a number of years that I'd be the one to do that until I moved back from Puerto Rico and I was working as a hospitalist in Southwest Washington, and I noticed that, patients would ask me, about this law, and I knew it was legal in Washington, but I had no idea how people could access it. And so I started to research on their behalf, and I came to End of Life Washington, and I tried to understand, who I could refer these patients to in Southwest Washington. And the list was quite small, just a couple of names on that list that were often overwhelmed with cases. And so it was by understanding that huge need that I came into this work. As we can all understand, in many areas of medical decisions and medical choices, something can be legal, but if we don't have medical practitioners to actually offer that service, then it doesn't make it an actual choice for patients. And so my strong feeling was that I wanted to be part of support for people who wanted to have this as their choice at the end of life. And again, like Judy said, dying well is as important as living well. And so I wanted to help support that for patients. So I became one of the providers. I took it upon myself to find some training down in California with one of the gurus of medical aid in dying down there. And I felt comfortable enough to come up and just start doing it. And I had a lot of great support. Bob Wood was being an excellent support this whole time, and other providers, both in Oregon and Washington, that have helped me along the way. And as my work in the hospital became more and more stressful during COVID pandemic, I continued to do volunteer work as a provider of aid in dying. And honestly, I found that to be one of the most rewarding things I did during those years. It became a way to connect with people that was felt very meaningful. And I was very happy to continue to have that in my life, in addition to this stressful hospital side of things during the pandemic. So serendipitously, I came to a place in my own career and my own life last late spring, where I was looking for some other work to do in addition to my clinical medicine, to kind of go hand in hand. And it happened to coincide with End of Life Washington looking for a medical director. So I'm here, and my biggest work here is to try to expand the provider network. And we are well underway with that, but there are a number of barriers. And I will say that as I go across the state and start to talk to doctors in areas of need, which is all of the areas really, but as I go and talk to the doctors, I'm hearing them say things over and over that are just becoming themes of what I'm hearing. And one of the things is that, just like me, most of the doctors who are engaged in this work find this to be one of the most important and rewarding things that they do for patients. It feels like something very valuable, and they love to be able to be a part of it. So that's a huge part of it. And I am happy to, always be able to tell new doctors that I'm bringing in, I think you're really going to find this to be very rewarding, because I know I do. And that's what I hear over and over. But that's not to say there aren't barriers. There's many barriers that we're facing as we try to bring new providers into this. And part of it is just education. Like me, many providers did not get educated in how this all works as part of their official training. And once you're in clinical practice and you have such a busy life, it's hard to make time for being educated on something totally new and outside your frame of reference. So a lot of what I'm doing is trying to provide that education, going around both to small and large groups and giving talks, and just trying to help people feel more comfortable about what aid in dying is, how the law is written, how it works, what's the process. And that's a huge part of them being willing to be part of it, is just feeling comfortable with it. And me and Bob and all the other providers that are willing to be support systems as they start coming into this is hugely helpful, I think, for a lot of them to feel comfortable. And then there's a lot of other things that I hear as barriers. The time within a busy practice to fit these visits in is always one. Paperwork burden, we have a somewhat archaic process still where we're having to fill out paperwork by hand and mail it in. In 2022, that seems rather silly when we know that they're just taking that paperwork and typing it into a database. So that's something we could be doing directly and probably would save us a lot of time and energy, not to mention postage. But that's part of the legislative push that another branch of EOLWA is addressing, is trying to reduce that paperwork burden, make it easier for providers. And then expanding access would be so hugely helpful. We know that in so many parts of the state, patients, primary care doctors, or even palliative care providers are nurse practitioners or physician assistants. And the fact that these people who know their patients well, and are definitely the best suited to be taking care of the patients at the end of their life, are not right now able to participate. And I think if we are able to expand the law so that we can have those people participate, we will see a huge amount of support from NPs and PAs, because I already hear them saying, oh, I wish we could participate. So, one of the things we've done already is to create a quarterly meeting for providers to get us all together in one place so that we can start feeling the support of each other. We can start discussing as a group some of the issues that are arising, and it helps us feel more connected. And that's been really, really nice. And we have our next meeting in January. There is a provider network. If there are any providers here that would like to sign up for the provider network, there's in the chat, you'll see a link to that. And that will get you into our network, where you'll get our emails about our provider meetings, about any other clinical updates and topics. And as we come out with videos or any other educational materials, we'll also let you be aware of that there. So please, if you're a provider and you're interested, go ahead and just sign up for that provider network that's in the chat. And then the second thing I'll bring up as another way for us all to feel connected, not only within the state of Washington, but within the national movement of aid in dying, is that second link there, which is the National Clinicians Conference on Medical Aid in Dying. And that's happening very nearby this year. It's February 17th and 18th down in Portland. And so for any of us that are wanting to be more connected to the national medical aid in dying community, I think that's going to be a fascinating conference. I think we're going to get a lot of really interesting topics and discussion and networking. So I really encourage any clinicians that are interested to register for that. Link is in the chat. All right, I think I will go ahead and pass it off now, Daniela.
Thank you, Jess. That was wonderful. And next up, I'm very excited to introduce Dr. Elizabeth Loggers. She's the medical director at Fred Hutch, and she will tell us a little bit more about the barrier studies that they're conducting right now. And I will let Dr. Loggers fully introduce herself. So please take it away. And thank you so much for joining us tonight. I know you're so busy.
Well, good evening, everybody. I apologize for the mask, and I'm obviously just finished in clinic, so I didn't have an opportunity to go to a place more appropriate for the meeting. But thankful to be invited and to have the opportunity to just describe a little bit about what we are doing. I'm going to try to share my screen. Unfortunately, I think the host will have to allow me to do that. I just have a couple of slides that just help keep me on topic so that I don't wander too much or take too much time.
And I just made you a co-host, so hopefully.
Thanks so much.
There you go.
Okay, so we were lucky enough this year to benefit from the Death with Dignity proviso, which was funding that Representatives Macri and Rood worked in a bipartisan way to achieve, to support a study of barriers to death with dignity. And we are working diligently to obtain the Washington State IRB approval for this. The structure of the study is actually one of statewide study of bereaved caregivers of individuals who have died in 2021, and trying to drill down to those individuals who, first trying to understand, are people really aware of this as a right that they have here? If they attempted to participate, what were the barriers that they achieved? So I'm not going to be able to talk about that because that's still in the works, but what I am going to point toward is some other things that we are doing and that Casa alluded to earlier in the evening. The first is we are conducting 2 studies with End of Life Washington, and we're incredibly grateful for this opportunity and for End of Life Washington's ability to take this on. They are both studies of patients and their informal caregivers. So what we mean by that are family and friends, basically loved ones, who might have participated in their effort to try to get access to Death with Dignity in the state. And so first we're looking backwards in time at individuals who reached out to End of Life Washington for assistance between 2020 and 2022. End of Life Washington actually informed them of this, informed patients and caregivers of this opportunity to participate in a research study via newsletter. And that has been actually, I think, relatively successful. We've had 140 individuals opt in and complete our survey. And so we're going to be pleased to be able to bring that information back to you at a later date and to include that in our report to the legislature. And then the second study is to look forward in time to people who are currently pursuing Death with Dignity. And we're hopeful that we'll be able to continue this for an entire year, not just for a short period of time while we try to meet the request of the legislature. Hopefully we'll be allowed to continue. But this is an opportunity to participate in a study whereby individuals, when they reach out to End of Life Washington, they indicate whether they would like to consider participating in a study. And if they do, then we are allowed to reach out to them to inform them of the study, educate them about that, and consent them. And, you know, it's very normal that this kind of thing would have individuals opt out because obviously the patients might be sick and they're busy. You know, they're in the midst of quite a lot of things that are going on, but we have had 10 individuals so far consent to participate. So excited about that work because we're really going to get, we hope, those barriers sort of, you know, directly from the people who are experiencing them. And we're hopeful that this will be representative of End of Life Washington's population, you know, statewide. And then there's some other things that we're doing to, oh, and I'm so sorry, I just realized I'm not doing full screen view. I apologize. It's probably hard to read or see. I don't know if that helps, but there are a number of other studies that we're also conducting related to this concept of barriers to death with dignity. One was a pilot study that we already conducted within our own advanced practice professionals here at Fred Hutch. It was a survey of ARNPs and PAs, asking them about their attitudes towards participating in Death with Dignity in response to the legislative effort to allow them to become prescribing providers. That pilot study of our Fred Hutch APPs was just actually published about a week ago in JAMA Open, but it allowed us to pre-test our questions, and we've since gone on to conduct a statewide survey. And so we are, that will close eventually, and we'll analyze that data and then hopefully do a better job representing attitudes of advanced practice professionals statewide. In working with Washington State Pharmacy Association, we're also trying to gather attitudes, perspectives, barriers from pharmacists statewide. And then finally, we are working to catalog the hospital policies and try to understand from them barriers to standardizing the reporting of whether they participate or whether they don't participate. So what we notice is that there's a lot of statements about hospitals complying with the law, but not really a lot of clarity about, well, what does that mean? People can comply with the law without actually being participating organizations. And so we're asking questions about that and about best practices and what would best practices look like for hospitals and hospital systems. that obviously have a lot of downward effects on the behaviors of their employees. And as part of that, we are interested in looking at access across the state and representing this in a way that helps people understand how difficult that can sometimes be to get access. So this is just an example of one of the things that we'll be presenting to the legislature. And it basically just looks at of the hospitals in a county, when a hospital exists in that county, what percentage of them actually participate. And by participate here, we do mean that they allow their employees to actually prescribe, dispense, and take the medications. So you're looking at Washington State map by county. And first and foremost, I hope you notice that, there are just some counties that don't have hospitals, which is, honestly, I have to say something I didn't realize, which is I'm embarrassed to say, but I didn't appreciate that some people were traveling so far to get to their closest hospital. And then there, you can see that there are basically vast swaths of Washington where a hospital might exist, but none of them participate. And so we're hopeful that this helps just kind of help people visualize the data in a way that maybe they haven't conceptualized previously, and that this will help drive legislative efforts that might be able to help rectify some of these things. So again, this is just a quick snippet of kind of some of the work that's going on, and we're hopeful to be able to come back at a future time to provide more real numbers and data about what we found in terms of the barriers. And you all know the barriers. So I appreciate that none of this is potentially earth-shattering, but again, we're hopeful to present it in a way that is compelling and helps clarify ways that we might be able to be more effective at overcoming those barriers. So this is how to contact me if you have concerns, questions, suggestions, thoughts, and I'm going to stop sharing.
Thank you, Dr. Loggers. That was wonderful. And once again, we really appreciate your time, and thank you for joining us tonight. Yeah, we will, as Judy said in the chat, we will definitely want to bring you back. And with that, next up, we are going to hear from Norma Timbang, who is a consultant with new transitions. And I'm hoping our speakers tonight all have very busy lives and are just getting out of other commitments to join us. So I'm hoping Norma is with us right now. Let's see. Norma, if you're here, please feel free to unmute yourself. Norma is here. Thank you, Alex. Thank you so much. So I will hand it over to Norma and I will let her introduce herself.
Daniela, could I also have the host capability to share?
Just one second, please. Okay.
Hello, everyone. Thank you so much for inviting me to share with you what we've been doing with EOLWA. It's a very important project, and we have so much we're doing right now with regard to identifying next steps. You will see we have a PowerPoint here that gives you a little bit of background. I'm going to try to make it as full of a conversation we can have, while still knowing that this is actually a very huge project and there's so much more information. You are also welcome to contact Judy, and Judy can let you know how to get a hold of us if you have other questions. The current slide is about why we do this work. So having great conversations with equity, inclusion, and diversity and belonging work is something that EOLWA showed some interest in. I am a consultant. I have a team of consultants who are working on things like we created a survey to identify what the climate of equity and inclusion is at EOLWA. We also have a couple of other consultants who are doing some things like we have someone from School of Public Health who also does work with the administration of long-term and aging. And one of the things that Anju will do with me is facilitate more conversations. So one of the things that we want to be clear about is the reasons you need to do this. Some people think, why is this so important? This is just taking up time. What I want to give you a sense of is that there's many reasons to do this. One of the essential pieces of making sure equity and inclusion happens is so that people have a sense of belonging. In that sense of belonging, you can have sustainable culture and sustainable people and a sustainable organization. That belonging actually creates a culture of wanting to be there, wanting to do the work, and wanting to make sure this organization is successful. We also want to think about, this is very competitive at this point. I do a lot of work with people who put out requests for proposals, grant opportunities. And in that work that I've been doing with the county and the city, we start to see that it's very competitive to have equity, inclusion, diversity, and belonging entrenched in your work. To center that work in very substantial ways gives you a competitive edge when you want to apply for funding. And also when you're looking for seeking out diversity of funding from not just from foundations and government, but from individuals. So this gives you a very competitive edge. The other thing is we can support the connection with our collaborative partners who are more diverse. If they see that EOLWA is doing this work, they will want to stay in connection. The research of equity, inclusion, diversity, and belonging actually shows that enhancing this in your organization creates a culture of longer worker tenure. We also know that the research shows that this worker relationship and productivity is sometimes very much tied to equity, inclusion, diversity, and belonging. So the other piece we want to understand is that potential clients at the end of life and volunteers need to see that this work is being done, so that if they're diverse clients that want this support, they see that you're doing this work. And they will start to feel, this is an organization I would like to support. This is an organization that I would love to support me. So this work of equity, inclusion, and belonging is essential. And so I'm going to also show you what is the avenue for us. What is the way to really think about this? Many of you are, as I am, what I call aging. We're older people, a lot of us. A lot of your volunteers are older people. A lot of the people that work with you are older people. One of the ways that I'd like to enter into this conversation is to actually talk about equity, inclusion, diversity, and belonging for people who are aging. What does that feel like? How does it show up? We want to think about what happens. The assumption that access through technology, that's one way we're impacted. People assume we can't use technology. People make assumptions about our cognitive or physical disabilities. They may not know us at all, but those assumptions are happening. Sometimes speakers who are talking to me, they are talking to me as if I'm a child. I know some of you have felt that. Doesn't feel great. Sometimes aging causes problems with things like job security. As we age, if we happen to get laid off, the opportunities to dwindle. So as we think about discrimination as well, we want to think about so many other ways where discrimination happens towards people who are aging. And when I think about elders or seniors, the other thing I want to think about is these kinds of discrimination actually happen to folks from other identities. We can talk about how this happens with gender bias. We can talk about how this happens with race difference. We can talk about how this happens with class difference, immigration status, etc. So the isms are crucial to understand when we're trying to work with equity, inclusion, and belonging. In the themes of our survey, we were very fortunate to get over 50% response on the survey of EOLWA. The idea is that we were asking about what do people feel or think or know about equity and diversity. So majority of respondents believe that EOLWA is doing useful work. towards equity, inclusion, diversity, and belonging. And they appreciate the work. We also know that some of the respondents might not yet know even what is equity, what is inclusion, what diversity is. So that gives us a next step. As we move forward, we want to make sure people get on the same page about what it is. Majority of respondents identify that in order to be ready for equity, inclusion, diversity, we need to increase that understanding of what accountability looks like in this process, in the practices of everyday work for EOLWA. And we want to make sure that there are people in a dialogue space where we can just talk about it. What are the struggles that we have with equity, inclusion, diversity, and belonging? The highest recommendation we received in the surveys was that we wanted to create and build more structure and support within the context of internal relationships of EOLWA. This includes the VCAs, the ambassadors, the staff, the board, etc. About 6 people, and this is out of 80 people, express concern about mission drift or indicate that EID work is not needed. Mission creep was mentioned. We've had quite enough has been mentioned. What I want to share with you is that I've already given you some good reasons to do the work. And I also want to invite folks who are feeling this way to have a conversation about it, to dialogue about it, to understand deeply what this work really is. 68 out of 80 people, 68% said that this is central to EOLWA's mission. EIDB work is central to EOLWA's mission. Majority of respondents felt like they had some sense of belonging. What's interesting here is that there was one person who said, I feel a sense of belonging because of my privilege. So not sure this question is really applicable to me. And incongruence to that, 19% said they don't agree. They don't feel like they belong. So what is that about? Let's work on that. Let's figure out what that is. 69% of 80 have the desire to engage in change towards equity, inclusion, diversity, and belonging. Some of the practices are getting into these conversations, doing some internal work with EOLWA, building those relationships, getting some more training that is relevant to what the folks need in EOLWA, recruiting diverse staff, which has been happening, and it feels like there's a sense of that's moving forward well. Want to recruit diverse board members, diverse volunteers, diverse VCAs. A list of these suggestions are available upon request. Finally, we want to clarify with everyone, what is equity, inclusion, diversity, and belonging? How can you engage? What are your opportunities? And where is our collaborative work and our transparency so that everyone can understand that this is a collective process? And the last piece I'll show you is this is kind of the goal. Not sure why I'm getting little green streaks in here, but the bottom line is Venn diagram, look at the center. The goal is to make sure people feel like they belong. And to do that, we have to understand what is real inclusion, what is real equity, and what does diversity mean? And in this context, we hope that you will find time to engage and just be curious about what we all can do. Thank you so much.
Thank you so much, Norma. We really appreciate you being here tonight and speaking to us about the survey. And next up, we do want to open it up for some questions. Some of them have already come in through the chat and have been answered by our staff members. I believe that there's one that we might have to refer to Dr. Loggers. Oh, and Dr. Loggers is still here. And I believe that she just answered that question in the chat. But yes, please, if you have a question, feel free to drop it in the chat, and we will do our best to answer them.
was a whirlwind of information.
Yes. Yeah, and Teresa, thank you for your comment. She says, thank you, Norma. I especially like the ordering of the letters and what that means. Starting with diversity instead of equity and inclusion is not the best approach. And Alex, can we unmute Jess? Thank you. And there's a question for Norma. What group was surveyed?
So the survey was, a survey link was provided to EOLWA, and they distributed it amongst VCAs, volunteers, board members, staff, and other folks who are affiliated with EOLWA. I believe it was over 100 people. Is that correct, Judy?
Yeah, I just posted in. It was about 120 people, I think.
Thank you.
Yeah.
Thank you. And Lashana asks, what can we do to support staff during this overwhelming time? I believe that question might be maybe Judy, Norma.
Or Daniela.
Yeah, I don't know if Lashana is referring to the growth in client numbers that we're seeing, or Casa as well.
Casa might have an idea.
One thing while we're waiting for Casa to answer that, I'll just say a question that came to me directly, but I think is worth mentioning on a broader platform is that there was a question if providers could join our meetings that we have on a quarterly basis, even if they aren't aid in dying providers. And I said, absolutely, yes, we're looking for any supportive or curious providers. We would still need them to register on the website with their emails so that we can give them the emails that will link them to the registration, et cetera. But they don't have to agree to already, provide that care just to be a part of those meetings. We are welcoming anyone that has curiosity and wants to know information.
Thank you, Jess. And Casa, I don't know if you want to try to answer Lashana's question. If not, I think she said we can answer it later. You tell me.
I don't really have a support staff answer. I think we do need more volunteer client advisors across the state. We need more folks to support clients. We have care deserts. And so if you think that that is something you're interested in, or you have somebody you know that might be good at this or be interested, please do encourage folks to volunteer with us as VCAs. That's supportive. And then the other thing you can do that helps staff is talk to your own providers, your providers that are friends, and ask them how they support end-of-life choices, if they prescribe and consult for medical aid in dying. We've all talked about how important it is that our healthcare itself become accountable and responsible for this process. It shouldn't be on end-of-life Washington's shoulders. And that happens by having more conversations with providers. And so if we're getting less and less clients that need providers because their own providers are doing it, that alleviates the stress and work for staff and volunteers.
Thank you, Casa. And I do want to point out, we love that we're getting so many questions. We might not get to all of them. And Judy, I believe that the next one I see is for you. It is essentially, what are the next steps to reintroduce 1141?
Yeah, so thanks for asking that question. So for the last several years, we've had a barriers bill that we've called it, that was HB 1141, that was designed to maintain the core protections of the Death with Dignity law, and also remove some barriers and remove some of the barriers that other states that have subsequently passed a law are including. And that includes, like, our waiting time is 15 days and we want to reduce that to 72 hours. And other states have 48 hours and so forth. And we wanted to add nurse practitioners and physician assistants to be providers. And there's some other things that are a part of that as well. And so we do plan on introducing it again this year. We are hopeful that we have a Senate champion in place to help guide it through the Senate process. And we've also added some improvements to the bill based on our staff's experience. And you heard Jess talk about paperwork. So we've added some things like that that are part of the original bill, the original law, to make those improvements. And so the legislative session starts January 17th, and we will be actively involved in it again this year. And we'll be introducing a new barriers bill that I think will hopefully be even better than the ones that we've had the last couple of years. And we're hopeful. So with the research that Dr. Loggers is doing, they'll have the reports done by, or a report done by December 1st to also help inform that process. But whatever we do, it's our opposition is strong and organized, and it will take as much work as ever to pass this bill. So thank you.
Thank you, Judy. And we are almost at time. So the good news is that all your questions are recorded in the chat. And I think we can try to figure out a way to get those answered and just send out to everybody who registered. So if I could have just one more minute of your time, I would just like to thank you all so much for joining us tonight. We would like to close by spending a few minutes talking about the importance of community. EOLWA would not exist without its robust community of volunteers, staff, board members, and supporters. If you're already part of this community and want to do more, please consider joining our visionary circle or contacting your representative to support the bill that we will have in the legislature this upcoming January. If you're brand new, a newcomer, and want to become a part of the EOLWA community, please consider becoming a volunteer client advisor, ambassador, or provider, giving a donation, or signing up for a newsletter, in addition to some of the other options that I just mentioned. As Judy mentioned, it really takes all of us working together to protect Washingtonians' access to end-of-life choices. And I believe that Raven was kind enough to share some of the links to some of the options I just mentioned in the chat, but we will also make sure to send them out in a follow-up email. And once again, thank you all so much for joining us tonight, and we wish you all a good evening.
Thank you. Thank you everyone for coming, and thanks for our guests. Thank you so much.
Yeah, thank you so much to our speakers.
And Daniela, thanks for being such a fabulous host. Thank you so much.
Thank you.
And I'll just have one last plug in for anyone that has connections to medical schools, residencies, anything where we have a personal into someone where we might be able to get educational materials or do presentations. Please send those my way or to CASA, and we will certainly follow up any leads we get. So we know that those personal connections often make the difference. So please send us what you got.
Thank you.
Right. Thank you so much.
Thank you.